Good evening, everyone. This is Meldita and I'm back. So our topic will be non-STEMI versus STEMI, English version, and this is part 1. Okay? So non-STEMI is a small heart attack, while STEMI is a big heart attack. So what will an RN do? On my left side here, we have an example of a non-STEMI 12-lead ECG. And if you notice, we have a ST depression in V2, B3, B4, and B5. Sometimes we have 12-lead ECG for non-STEMI, which is negative. You don't see any ST depression, but the troponin is positive. Okay? And on my right side, we have here a STEMI, ST elevation MI. And you notice an ST elevation on my example in here. This is a 12-lead ECG with inferior STEMI, ST elevation in lead 2, lead 3, and AVF. But this is a subtle or mild type of STEMI. So the question is, why do we have an ST depression in non-STEMI? Okay, based on the diastolic injury current here, we have a damage or segment of subendocardium here. So this is where the ionic leak comes or, it occurs. So when you say ionic leak, with ionic leak, some of the sodium gets in, some of the sodium get in, and some of the potassium come out. So ionic leak will come from the damaged subendocardial region, okay? And that follows partial depolarization. There should be no depolarization happening during diastole, but in here it happens. So there's a partial depolarization during diastole. Electrical forces are created, and they're moving toward the electrode. And this causes the baseline to move upward. There is a full depolarization and stimulation that follow, and then an ST depression is created. In the case of STEMI, based on the diastolic injury current, why do we have an ST elevation? We have a myocardial injury here. Remember, in the non-STEMI, it is subendocardial, but in STEMI, we have a myocardial injury. Actually, it starts from epicardial down to the muscle, deeper. Okay, so again, we base it on the diastolic injury current in here. Okay, so ionic leak will come from the injured myocardium. Okay, partial depolarization follows. Electrical forces are created, and they move away from the site. If you see the arrow, they move away from the site. This causes the baseline of the ECG to go downward, and after full depolarization and stimulation, an ST elevation is created. But there is also a STEMI based on systolic injury current here. Okay, this is different. So in here, you see that the action potential, that is one cell electric, stimulation. When you say action potential, it is the sum of the depolarization and repolarization. But in this case here, we have a resting membrane potential which is shorter. That is the dotted red colored line here. So this one is positive minus 90, so this is shorter. And you see that the repolarization is faster. So what happened there is that when we have this rapid repolarization, that's rapid repolarization, the surface of the ischemic cells will become relatively positively charged. Okay. And what's going to happen? The current is moving towards the electrode. Okay. And then followed by the inscription of an ST elevation. This is based on systolic injury current. Okay. So, again, when you say diastolic injury current, there's a problem here. We have a partial depolarization happening during diastole for both. But for systolic injury current, it is the repolarization that becomes shorter or more rapid. Okay? That's it. And it will inscribe also an ST elevation. So now, non-STEMI and STEMI. So what we nurses normally do when we have a non-STEMI, our patient will come or will be admitted from emergency, from other units in the same hospital where we work, but because they have non-STEMI, they will be admitted to CCU. Okay, that is the coronary care unit. Okay, when a patient arrives in the unit, this is a teamwork. So when the nurse in charge or assigned to the patient will be busy admitting the patient and getting report from the ER nurse or from the other unit, the other group, our co-staffs, they will be busy settling the patient. So they will welcome the patient to the unit. They settle patient in bed. They hook the patient to the cardiac monitor, check IV medications and other tubing connections and other contraptions, check for any ongoing discomfort, and give brief report to the admitting RN. This is a straightforward admission. With regards to the admitting registered nurse here, so the CCU RN gets report. Report is brief but informative. And the nurse giving report will mention the chief complaints and the diagnosis, history present illness. We have here the past medical history that includes the risk factors like hypertension, diabetes, high cholesterol, smoking. The ECG will reveal ST depression, or it could be normal. The blood works will be mentioned as well that is positive, which is why the patient is ending up in our units in CCU. They do chest x-ray just to rule out other problems and management of other problems that occurred in the unit or in emerge. They will tell everything what happened and what they did. And the patient will be referred and seen by the cardiologist and will be accepted. The patient will be accepted. Orders will be made, will bring upstairs, and the plan is for angiogram. This is not an emergency angiogram, and this could be done later that day, I should say, or that could be done the following day. So after report, then the nurse in charge of the admission will go right away to the patient and do her thing. So the assessment, baseline, everything will be mentioned on my next topic. So we're just talking about how the patient is being received in the CCU. Okay? So here in STEMI, we have an admission coming from the cath lab to CCU. So the patient will come from the community. They come from the other hospitals, or they could be in the same hospital or in the other units, but they all suffer with ST elevation MI. But they go first to the cath lab to have an emergency or primary, procedure. It could be a primary PCI or percutaneous coronary intervention or whatever they find there. But one thing for sure, they're all ST elevation MI patients. So when the patient arrives in CCU, again, the co-staff will settle the patient. Other management, the same as non-STEMI, plus also arterial closure management precautions. And the admitting RN will get report from the cath lab nurse. And again, the report is usually brief from the cath lab and informative. And they mention again the chief complaints, diagnosis, history present illness, past medical history, including risk factors, what they did in the cath lab, and what other management or events that happened and being managed. Okay, and they will tell us what kind of STEM is this. Is it anterior, inferior, lateral, or whatever they find or whatever they found out and managed in the cath lab. Okay, so my next topic will be more assessment, and we will be talking more about our nursing documentations. But right now, we just have to understand a little bit of the ST formation abnormally, non-STEMI for STEMI, and also both diastolic injury current and systolic injury current. Okay,